Hello and welcome to this topic of infectious diseases. Today we're going to talk about tuberculosis. By the end of this module, you should be able to define tuberculosis, explain the bacteriology of this condition, summarize the pathogenesis, outline the population that is at risk for this disease, recall the clinical manifestations, understand the approach that needs to be taken to establish a diagnosis, formulate a management plan, outline the treatment challenges and outcome of treatment. Let's get started. Tuberculosis is a multisystemic infectious disease caused by the bacteria Mycobacterium tuberculosis. What does the epidemiology look like? About 30% of the world's population have latent infection. At any one time, about 10 million people across the world have active tuberculosis infection. In 2017, the largest number of new TB cases occurred in the Southeast Asia and Western Pacific regions with 62% of new cases, followed by the African region with 25% of new cases. Tuberculosis is caused by the organism Mycobacterium tuberculosis. Unlike the bacteria that causes typical pneumonia, this bacteria is slow growing. It takes about 4 to 6 weeks to culture in the lab. Its unusual cell wall, which is rich in lipids, is responsible for its resistance to desiccation and is a key to virulence factor. There are other subspecies of this organism such as Mycobacterium africanum, Mycobacterium cannati, Mycobacterium bovis. Mycobacterium bovis in its inactivated form is used as a vaccine which is known as BCG. Another relative of this microorganism is non-tuberculous mycobacteria or NTM. It is an environmental mycobacteria and do not cause tuberculosis or leprosy. NTM do cause pulmonary diseases that resemble tuberculosis. Pathogenesis. Let's look at the pathogenesis of this infection. It can only be spread through air droplets originating from a person who has the disease either through speaking, coughing or sneezing. When in the lungs, Mycobacterium tuberculosis is phagocytosed by alveolar macrophages, but they are unable to kill and digest the bacterium. Its cell wall prevents the fusion of the phagosome with lysosome. The bacteria evades macrophage killing by neutralizing reactive nitrogen intermediates. Protective granulomas are formed due to the production of cytokines and upregulation of proteins involved in recruitment. This is the hallmark of the disease. When a person comes into contact with another who has positive sputum AFP pulmonary tuberculosis, the bacteria is inhaled and reaches the lungs. There are three possible outcomes to this. 50% of the time it is cleared with no infection. Another 45% of times it turns into latent infection. The remaining 5% will develop active primary disease depending on their host factors. Some of the active primary disease will heal with treatment. The disease can be reactivated in those with latent infection 10% of the time. There is an increased risk of reactivation in increasing age, malnutrition, use of steroids, HIV infection, and in the use of anti-tumor necrotic factor treatment. Sometimes, patients may develop clinical syndromes, which is a progression from the primary disease, and these include gastrointestinal TB, TB lymphadenitis, pleural TB, pericardial TB, TB osteomyelitis, and septic arthritis, and also TB meningitis. Who is at risk? The basis of those who can easily contract this disease is that if they come into contact with those who are infected, for example, healthcare workers who work in high-risk areas. Many are found to have disease when they have come into contact with immigrants who have immigrated from areas of high TB incidence. Residents and employees of high-risk congregate settings such as prisons, nursing homes, homeless shelters, drug treatment facilities, and healthcare facilities. Immunosuppression also plays a role in this disease. Those who are on long-term steroids, have diabetes mellitus, infected with HIV, and use illicit intravenous drugs are at risk as well. So the classic symptoms of pulmonary tuberculosis are, like other lung infections, cough. But the chronicity of the cough associated with night sweats are the giveaway points. They may have cough with hemoptysis. They also may come in with systemic symptoms because TB is a systemic infection, and this can lead to constitutional symptoms like significant weight loss and appetite loss as well. The clinical manifestations of tuberculosis can be shown by the lung alone, which is pulmonary tuberculosis, or lung plus other organ involvement. The non-infective group of tuberculosis infection is the ones without pulmonary involvement or extrapulmonary disease. The commonest extrapulmonary tuberculosis is TB of the lymph nodes, and this includes mediastinal lymph nodes as well. Miliary TB is a disseminated form of infection as the infection is spread hematogenously throughout the body. Other forms are such as TB meningitis, TB pericarditis, TB colitis, TB cystitis, and Pott's disease, as well as the lymph nodes which we mentioned earlier. Radiologically, consolidation or cavitating lung lesion is characteristic of pulmonary tuberculosis. Mediastinal lymph nodes also can be seen, and if the infection has extended involving the pleura, then exudative pleural effusion is also seen. This fluid is sampled for testing. Diagnosis of tuberculosis requires a positive Mycobacterium tuberculosis culture. However, it may take up to 4 to 6 weeks for the culture results to be complete. In the meantime, we use telltale evidence like positive AFB staining from the sputum. Biopsies and aspiration from extrapulmonary sites too can be done. Latent TB is identified by immunological response to TB antigen. Examples of tests include the tuberculin or MEN2 test and the interferon gamma radioassay test. Now, let's look at the treatment for tuberculosis. The standard treatment regime uses quadruple regime therapy, which is 4 drugs in combination for the first 2 months, followed by 2 drugs for the remaining 4 months. Most sites of the disease require 6 months of therapy. However, the nervous system and bone disease treatment can extend up to 12 months. Let's look at the drugs individually. Isoniazid is a drug that kills the mycobacteria rather rapidly. Isoniazid is the reason vitamin B6 is given together in the treatment cocktail, as this drug can cause peripheral neuropathy. Rifampicin, on the other hand, kills the slowly replicating mycobacteria and has to be continued until the end of therapy. Rifampicin causes orange discoloration of the urine, which is always informed to the patient prior to prescribing. Pyrazinamide and ethambutol are given for the first 2 months. Regular eye screening is needed as ethambutol can lead to optic neuritis, which is usually reversible with discontinuation, though irreversible blindness has been reported. Adjuvant steroids are prescribed for CNS and pericardial TB infections. All TB cases has to be notified. This is to allow contact tracing to be done. Contact tracing, even though the treatment regimen is pretty standard for all cases, various problems are faced in this process. Establishing a concrete pathological diagnosis is a challenge as the culture growth is slow and may take up to 6 weeks to show a positive culture. Many a times, empirical therapy is initiated and response to treatment is evaluated based on clinical response. Other problems faced is compliance to medication. Most patients find it tough to be consistent, taking many tablets a day at a fixed time. Sometimes adherence issues can also be secondary to side effects of treatment. Drug-induced liver injury can be serious and may need change of treatment regimen. Drug-resistant disease is a constant battle which often occurs when only a single agent is used and patient misses their doses. Drug-resistant TB needs a longer duration of therapy and can be fatal if they fail to respond to treatment. Non-resistant TB is readily curable. However, extensive disease can lead to complications that may not be reversible. Some patients may experience poor respiratory function due to fibrosis, bronchiectasis, pleural thickening. Cavities colonized by mycetoma can lead to non-resolving hemoptysis. And if one develops bronchiectasis secondary to tuberculosis, this predisposes them to recurrent infections and hospitalizations. Respiratory failure can be a result of fibrotic lung parenchyma, airway disease, or pleural thickening. In summary, tuberculosis is a chronic indolent cavitating granulomatous disease affecting the respiratory system. However, involvement of other organs are also seen. Asymptomatic infection is called latent tuberculosis. It is an airborne disease. TB is based on chest x-rays as well as microscopic examination and culture of body fluids. Diagnosis of latent TB relies on the tuberculin skin test. Active TB is best treated with combinations of several antibiotics to reduce the risk of the bacteria developing antibiotic resistance. We have come to the end of this module. Thank you.